So my name is Antonio Raimi. I will be doing Graves' disease for my autoimmune disorder. So what is Graves' disease? So Graves' disease is also known as Basedow's disease. It was originally termed the exophthalmic goiter, which is characterized as an autoimmune disorder that predominantly affects the thyroid gland. It's characterized as an autoimmune disorder, which results in increased synthesis and release of thyroid hormones, which causes many downstream effects. It's more prevalent in females than in males, and this may be due to hormonal mechanisms. We're not completely sure exactly why this is. It is considered to be organ-specific, as it does primarily affect the thyroid gland. However, complications may affect other organs if left untreated. It's associated with a type 2 hypersensitivity reaction, meaning it's mediated via antibodies, or in this case, autoantibodies. If left untreated, it can result in death because those downstream complications can be life-threatening, such as heart failure. So some thyroid anatomy and pathogenesis. So the thyroid gland is a butterfly-shaped endocrine gland located on the lower front part of the neck, just below the larynx and in front of the trachea. It plays a crucial role in regulating various bodily functions through the production and release of thyroid hormone. So just a few little terminology to get through. TSI refers to thyroid stimulating immunoglobulin. We have TSHR, or the thyroid stimulating hormone receptor. And lastly, TSH, which is the thyroid stimulating hormone. So overall pathogenesis of the disease works in this fashion. You have autoreactive B cells that produce, via many different factors that we'll get into, these thyroid stimulating immunoglobulins, which are autoreactive. And so normally in a functioning thyroid, you have via the pituitary gland a release of TSH, or thyroid stimulating hormone, which binds to the thyroid stimulating hormone receptor on the surface of thyroid follicular cells, the primary cell of the thyroid. And once that happens, that binding activates the production of T3 and T4, which are respectively triiodothyronine and thyroxine. And that increased expression results in glandular hyperplasia, which is basically the enlargement of the thyroid gland, as well as eventually hyperthyroidism. So the issue here is that in a normal functioning thyroid, you have TSH, which binds to the TSHR. In this case, however, you have molecular mimicry via the TSIs, which take the place of TSH, binding to the thyroid hormone receptor, thyroid stimulating hormone receptor, TSHR. And there's no immune tolerance mechanisms to kind of prohibit this. And because there's no negative feedback loop for the TSH, which we'll get into for the TSI, you have excess production of T3 and T4, which leads to all of our issues. So in this case, we have an image of thyroid tissue within Graves' disease and a normal thyroid. What you can see is these follicles are nice and circular, whereas in the Graves' disease tissue, they're very irregularly shaped. You also see all of these bunches of nodules. These are the thyroid cell nuclei, which have become enlarged via that glandular hyperplasia. And you can also see that the cells here are kind of tall and columnar in shape, whereas down here, they're much lower and cuboidal in shape. And so this is just here to show you a little bit of the differences. Whereas here, we just see some of that anatomy. So the immune response and initiation. So this is kind of interesting. What we see here is there's several different factors that contribute toward the autoimmune disease. So first of all is genetic predisposition. So there's evidence to suggest that genetics plays a vital role in predisposing individuals towards Graves' disease, mainly in our human leukocyte antigen, or HLA genes, particularly HLA-DRB1 and HLA-DQB1 regions, which have been linked to increased risk in Graves' disease, as these play an important role in the regulation of immune responses, and specific variants can contribute to the autoimmune responses. You also have things like environmental factors, and so these are things like that can trigger the autoimmune reaction. And these include infections via bacterial or viral, pregnancy, smoking, or exposure to certain chemicals such as polybrominated diphenyl ethers. And so this basically triggers the activation of the immune system and initiates an autoimmune response in those susceptible individuals. So infectious pathogens may also share structural similarities with self-antigens present on the body. So this is that molecular mimicry via the TSI of the TSH to the TSHR. And this leads to that stimulation of thyroid hormone production, leading to excess production of T3 and T4. And so this image here is just to show you that these autoimmune diseases very often have many different factors that go into why they form. And so genetic predisposition, environmental factors, immune regulation or lack thereof, and many, many more. So the innate response. So what we can say is we don't know too much about how the mechanisms of this disease work. So within the innate response, we can say that your dendritic cells, which are your professional antigen-presenting cells, capture thyroid-specific antigens and present them to those autoreactive T cells, which triggers the responses to the thyroid follicular cells, mainly the destruction. You then have presentation, which triggers activation of more autoreactive T cell responses, which then exacerbates the production of T3 and T4. Macrophages are like dendritic cells in that they can also function as APCs and present antigens such as thyroglobulin and thyroid peroxidase. They can also secrete pro-inflammatory cytokines, which leads to increased inflammation of the thyroid tissue, which can further lead to the destruction of those thyroid follicular cells. You also have things like natural killer cells, and while their exact role is unclear, they may be involved in the destruction of the thyroid follicular cells either via cytotoxicity or through inducing an apoptosis pathway in response to the dysregulated thyroid antigen expression. Next, we get to the adaptive response, and so here we're going to be mainly talking about B and T cells. So T cells recognize self and foreign antigens, which, when such antigens are processed in small peptides and bound molecules coded for by genes of the HLA region on chromosome 6. And the portion of the T cell responsible for this is the recognition, is encoded via your T cell receptor complex. And they found that mainly T helper cells are involved in this autoimmune response. And so these thyroid-specific antigens, such as thyroglobulin or thyroid peroxidase, or the TSHR, within the confines of Graves' disease, it's understood that the autoreactive T cells recognize these thyroid-specific antigens as either aberrant or foreign, which leads to that breakdown in immune tolerance mechanisms. For your B cells, we know that B cells play a vital role in the autoimmune response that makes up Graves' disease, as they are the source of your TSIs, which then stimulate hormone receptor. They bind to the receptor, chronically stimulating it. The TSHR is expressed on the thyroid follicular cell. Thus, the consequence of this chronic stimulation is an increased production of the thyroid hormones T3 and T4. Then you get to kind of the interplay between T and B cells. So B cells are also capable of serving as antigen-presenting cells, and this is due to the B cell receptor, which enables the identification of specific antigens against which they can initiate an immune response and synthesize antibodies. So antigen fragments are then presented to CD4+ helper T cells via your MHC2 identifier molecules. And in the case of Graves' disease, it's believed that these foreign antigen presentation via the B cell may contribute to the activation and expansion of the autoreactive T cells, which then just furthers that hyperthyroidism from excess T3 and T4. So in this graphic, we can just see the interplay between the autoreactive T cell and the autoreactive B cell, which then produces those autoantibodies, your TSIs, which take up the spots on these TSHRs, leading to that chronic production of your T3 and T4. And then in this graphic, we can kind of just see the thyroid cell functioning properly and improperly. So on the left, functioning properly, we see our TSH produced by the pituitary gland binds to our TSHR, which then stimulates hormone synthesis and then production. However, in this case, there's a negative feedback loop that as you have that increased production of thyroid hormones, you have then a deregulated production of your TSH, which then stops that process. However, with Graves' disease, it's not the TSH that binds to the TSHR, it's this autoantibody and via this TSI. And the TSI doesn't have that negative feedback loop, so it's a chronic stimulation, and this results in that unregulated overproduction of thyroid hormones. So symptoms, so Graves' disease manifests itself through several symptoms. Hyperthyroidism, one of those common hallmarks of the disease, can include things like weight loss despite increased appetite, rapid or irregular heartbeat, nervousness or irritability, trouble sleeping, muscle weakness, sweating, frequent bowel movements, and maybe even an enlarged goiter. You can also have issues with your eyes, which manifests itself as Graves' ophthalmology, such as bulging eyes, light sensitivity, pressure or pain in the eyes, and then blurred or double vision. Graves' dermopathy is very rare, however, it can also happen wherein patients experience a reddish and thick patch of skin with rough textures. These are mostly benign, they're mild and painless. And they usually form on the shins, but they can affect the top of your feet. So further complications, right? So a failure to properly treat Graves' disease may result in the following. You can have several different cardiovascular complications, such as arrhythmias, which is basically the condition of abnormal heart rhythm, particularly atrial fibrillation, which can result in heart failure or seizures, tachycardia, which is just basically an increased heart rate leading to heart palpitations and potentially damaging the heart muscle over time, and then hypertension, which is just increased blood pressure. You can also have things like a thyroid storm or thyrotoxic crisis. This is very serious. It's rare, but life-threatening condition that can occur when the thyroid hormone levels become excessively high. This is a life-threatening issue, and if proper medical attention is not given, death is often the outcome. You can also have several metabolic complications, bone health complications resulting in osteoporosis, decreased bone density. Reproductive issues, especially for women, in rare cases can result in infertility, often disruption of menstrual cycles, and it can carry over to a child in the womb via things like preeclampsia, preterm birth, and low birth weight. And so here we just have an image of that thyrotoxic crisis, which is a hallmark of the disease, and physicians can use these images to diagnose. So diagnosis. So there's basically four main methods of diagnosis. The first are your blood tests, which basically measure levels of thyroid hormones as well as TSIs in the blood. These are generally the primary measure taken to eliminate other causes of exhibited symptoms and isolate the thyroid as the target of an autoimmune response. Next up, we have radioactive iodine uptake tests, and these measure the amount of iodine the thyroid is taking up via the bloodstream to make thyroid hormones T3 and T4, and that iodine profile is what's really important there. Next up, you'd have your thyroid scan, which often is paired together with the thyroid radioactive iodine uptake test, and this test basically figures out and displays where and how iodine is distributed within the thyroid gland. This is done as how iodine is distributed within the gland in question can often be used as a source of diagnosis. As seen here, very dense spread throughout iodine, spread throughout the thyroid gland is often a hallmark of Graves' disease, as well as other causers, as you can see right here. You also have things called the Doppler blood flow measurement test, and that's what's happening in this image, and the graphic down here shows how it works. It's also known as the Doppler ultrasound, uses sound waves to detect increased blood flow in the thyroid gland due to Graves' disease. And a physician may order this test if the radioactive iodine uptake test is, not appropriate for the patient, whether they might be breastfeeding or pregnant. So treatment, unfortunately, there is no cure for Graves' disease. However, there are several treatment routes to eliminate symptoms from the disorder. So the first up, we have beta blockers, and so these basically block the action of adrenaline or epinephrine and related hormones, and what this does is alleviate symptoms of hyperthyroidism, such as increased heart rate, heart tremors, anxiety, sweating, things like that. Next, you have antithyroid medications, and so these drugs work by inhibiting the production or inhibiting iodine from the thyroid gland, which then in turn inhibits the production of T3 and T4 because you can't produce them without iodine. This often can result, though, in hypothyroidism, and thus a synthetic form of T3 or T4 has to be taken into account. Something like levothyroxine might be just prescribed by a physician because you no longer have that source of T3 and T4 naturally. You have two other options, the radioactive iodine treatment. And so this is a non-invasive chemical destruction of either parts of or all of the thyroid gland, as well as surgery, which is the invasive manual removal by a surgeon of the thyroid gland. In both cases, the thyroid gland is usually taken out of the body, basically, in these two options. And so these will also result in chronic hypothyroidism, and you're going to have to take a drug like levothyroxine to substitute. And so this graph right here just kind of shows the treatment methods for Graves' disease. And so you have the conservative route, which is like your antithyroid drugs. And these work, however, often you have a high relapse rate. For a more ablative treatment, you have things like that radioactive iodine treatment, your radioiodine, or your thyroidectomy, the surgery, which removes the thyroid gland and results in that lifelong hypothyroidism, which is going to have to be addressed by a physician. And that will basically result in you taking levothyroxine for the rest of your life. But yeah, that's about it. Thank you so much for listening, and I appreciate it.